Wish to welcome everybody to San Antonio. Thank you so much for coming. We apologize for the cold weather. Us native Texans are freezing to death right now. Anytime it goes below 90 degrees, we have a difficult time in really believing in global warming. So please accept our apologies on that. But for those of you from the snow country and further north, please enjoy it. Please see it's not a canal, aunts, it's a river. Please enjoy our river walk and all of its attractions. Also, please pay a visit to the Shrine of Texas Independence and Liberty, the Alamo, which is just about 4 or 5 blocks that way. And I think if you go in there and really study the Alamo, that you'll understand why Texas is so truly independent. Also, I would like to say, as you visit the Riverwalk in the Alamo, please don't spend all of your money there. Go out here and buy the T-shirts and the Coke bottles and the tape recordings, because that money goes to this cause. And this cause is for these patients, and we would really appreciate it if you could donate some of your financial capabilities to what's out there. And we certainly thank those that contributed those gifts. Read about them out there. It's quite an effort. Of course, my name is Randall House, and I'm chairman of the IPA and president of AMDA. And I would like to again welcome all of you to San Antonio, especially the patient group. We know how difficult it is for you to travel, and really appreciate your attendance. I'd like to go through just a little brief history and then a round of thank yous that are due. This year, 2006, is just a tremendous year for us. And of course, the reason is that we have commercial approval for Myozyme, finally. As you know, this project actually started back in 1932, when J.C. Pompey first researched the disease and came up with some of the symptoms of it, etc. But the real work has not only progressed, but it's really been accomplished during the past 15 or 20 years. And I would like to think that it's really advanced in the past 12 to 15 years. And one of the reasons that we believe the advancement has been so rapid and successful, I know 15 years doesn't sound rapid, but in this type of research it is, believe me. 13 or 14 years ago, when our daughter Tiffany was diagnosed with Pompe disease, there was no patient organization, and there was a very loose-knit group of research scientists that needed to collaborate, needed to get together, and we saw that need, and we were directed by some of those researchers towards that need, and successfully got them together at many conferences like this, which expanded over the years and led to a joint effort of research, competition, involvement of industry, and led us where we are today. It's been a very difficult path. It's been a very long road, very expensive road. A lot of challenges, a lot of disappointments, a lot of successes. And for those in the patient community here today, you're going to have the opportunity to get to hear some of these some of these researchers that are truly the leaders in this field. Y.T. Chen with Duke University. We started early with him and a young man named Johann von Hove, and which led us to Arnold Reuser, Hans van der Ploeg, the Dutch community, the experience of the transgenic enzyme with the rabbits, the development of various cell lines. The story is very long. Excuse me, very long. I get emotional on this, as you can understand why. But it's a long story, but it's a successful story. And goes back to the days of farming with the rabbits. And I recall meeting Herman the bull, who was one of the first animals to have human genes implanted into him. But that story is now bearing fruit. And with the commercial launch of Myozyme in both Europe and now the U.S., and through the hard efforts and continued efforts of Genzyme Corporation, it's proving to be successful. We should all realize, however, that this is just another of a series of many steps to come. There will need to be continued improvement of the medicine, more research on the causes and effects of the disease, more efforts in physical therapies, diet therapies, genetic information, genetic coding, screening, newborn screening, screening in the adult populations, improvement of screening, identification of mutations, and on and on and on. But the main point now is, thanks to these researchers and this corporation, we have taken the huge step of them providing us with a therapy for this disease. And that there cannot be enough thanks given to all of those that have been involved in that work, and we truly appreciate it. And like I say earlier, we feel that the work of the AMDA and the IPA have been instrumental in bringing this to this point. I give special thanks to Ria Broekgaarden from Barn, the Netherlands, and all of her work efforts involving the IPA and uniting the patient groups worldwide together. She's very, very dedicated, and we couldn't ask for a better person to be secretary of the IPA. A man named Ishbran Portman, also from the Netherlands, and I started the IPA in 1999, and she's carried it forward since then. Besides thanking the corporate sponsors such as Genzyme and Quorum, thank you very much for your participation here and the sponsorship of this. To me, personally, the greatest round of thanks goes out to my wife, Marilyn, and to Tiffany for everything they have done to develop this whole process and try to help the patients. We owe Marilyn and Tiffany a great round of respect and gratitude, and we thank you so much. With having said that, I would like to turn things over to the into the director of the presentations and the chair, Dr. Arnold Reuser. Arnold Reuser, for those of you who don't know, is from Rotterdam, Netherlands. Great friend, unbelievable researcher in this field. works together with all of these scientists, and has tremendous respect in the community. So now I'd like to have Arnold take over, please.
So welcome again to the AMDA IPA patient meeting here in San Antonio. And for those of you who don't know how the business is being run here in San Antonio, I was appointed Master of Ceremonies and I had to accept. And of course no one told me what my duties would be. So my acting these 2 days is a reflection, I call it, of unrestricted personal interpretation of my job. It's going to be a very nice meeting, and everything else, of course you will understand, was organized by the AMDA IPA, and we are very, very grateful for their efforts. Special thanks, of course, go to the local organizers, the family house, and of course they got great assistance by Marcia Zimmerman, I heard, and probably also many other people. As to the format of this meeting, it is meant to be informative, interactive, so raise your hands if you have any questions, interrupt, and the atmosphere will be very open. The purpose of this meeting is to raise awareness of Pompe disease. I copied it from the AMDA site because I didn't get any extra information. And the second purpose is to provide patients with current information that will impact their lives. It's all very black and white. The centerpiece of this meeting, that's you, the patients. You are the great majority here. Make sure that you get the best out of it. And also, of course, you have to make the meeting yourself. So act. That was part A of my brief introduction. I go to part B. It's about the disease. Everyone knows many different names. I've used different types of letters, kind of show the changes during time. It's called Pompe disease. It's called glycogen storage disease type 2. It's called acid alpha-glucosidase deficiency or acid maltase deficiency. And also these days you will read GAA deficiency. Mostly these days people use Pompe disease. In Europe we say Pompe, but this meeting will be Pompe. Also this, very black and white. Apparently that's the style of the AMDA. My style is different. It's Pompe disease, acid maltase deficiency for this meeting. And I go to part C. A little bit about the history of AMDA and the IPA. Wait a minute. Oh, that's black. That makes sense because the IPA came out of the blue. There it is, out of the black in this case. And it was in 1996. There it is, AMDA. No question they were there. They're still here today and alive and kicking, I call it. The first meeting was organized by Randall and Marilyn House and was held here in San Antonio. It was a scientific meeting. That was in 1996. I have given it a personal label and called it surprise and expectation, because for me it was a big surprise. The family house called in scientists from all over the world, and I met people I had never seen before, and there was expectation about whether there would be a cure in the future, yes or no. One of the slides I used in my presentation here symbolizes the common feeling we had that meeting, that all of us together, we thought we were close to having a therapy for Pompe disease, but there was still a gap that needed to be bridged. The second meeting was held a year later, also in San Antonio. I've given it the title, A Year of Changes. The gap was closed, and one of the big changes was that companies got involved. There was Farming, the Dutch biotech company, and they had a program to develop the production of human alpha-glucosidase in the milk of rabbits. While at the same time, Dr. Chen and Dr. Van Hoven Their name has already been mentioned. Of course, they are the two at the right, I'm at the left. They found a sponsor, Simpec, a company willing to support the development of the production of human alpha-glucosidase in Chinese hamster ovary cells. The procedures are in principle not very different. Either you put the human DNA coding for the alpha-glucosidase into a Chinese hamster ovary cell, CHO at the bottom, and you grow these cells in a steel fermenter. Then you harvest the medium and you extract the enzyme. This is the procedure they use for the production of myozyme today, which is now being given to the patients. The other procedure that has now been abandoned was to inject the same DNA into a single-cell rabbit embryo to milk the embryo, the rabbit, of course, the rabbit, and then extract it. From then on, there was a fierce competition. Which product would be first? Would it be the rabbit, or would it be... right? Another year. Both products, of course, you know, were tested in the clinic. The third meeting was held in 1998. I have labeled that meeting NIH, Fresh Troops. It was organized by Dr. Paul Plotz and Dr. Nina Rayban, of course, together with the AMDA. And has been, and also, why Fresh Troops? Not only NIH brought support, but also the IPA came into existence, the International Pompe Patient Association. This is one of the recent folders the IPA produced in a series of folders about care around Pompe disease. Then there was the German Alliance of the IPA. They contributed this book on Pompe disease that was published a few months ago. And speaking about fresh troops, last but not least, of course, Genzyme joined in. The meeting of 2001 was planned close after 9/11. The big question was then either to cancel the meeting or to go on. The only answer was, of course, there's only one way to go, and that's why I've labeled it this way. We have to go forward without any hesitation. Only one way to go also applied to decision making. On the final production process, it became myozyme produced in Chinese hamster ovary cells. Now we have come to the year 2006. I have called this meeting something to celebrate. This is one of the patients that we treated in our clinic. The patient, of course, was treated not by me, but by Dr. Ans van der Ploeg. This patient, in the first year, received the product from the rabbit milk, and then later switched to the product myozyme. So the patient is now on myozyme and is 7 years old. Unfortunately, not all patients respond equally well. I go to part D, and I'm almost at the end. That's about the program of this meeting. This was yesterday evening. We had a very nice evening, I think, at the SeaWorld. Now finally I know what a cool down is, but I won't be able to reproduce. I'll practice on it maybe, we'll do some on the next meeting. So this we have had, and then the rest of the program today. It starts with panel A, enzyme replacement therapy for Pompe disease. Panel B, after lunch, will be corporate and governmental perspectives in relation to enzyme therapy. Panel C is living with Pompe disease. That's this afternoon. And Sunday morning, tomorrow morning, we will have the future of Pompe research. Presentations with a more scientific view, but still very, very interesting. So I do invite you to be there. And it ends with patient perspectives by Maries Schoneveld. What do you have here? Oh, this is the job for now. We will have the first panel, and the chairman is Dr. Chen. And you will introduce the speakers, so may I invite you, and they will switch computers. Thank you.
I'm Chen. I have known many of you for many years, and but also I recognize there are many new people attend this meeting. The first time I'm meeting you. I want to first thank Randall House, Marilyn, and also the AMDA and also the IPA to bring again the doctor, the scientist, and patient all together again. And the first one was certainly 10 years ago. And the picture that time, I have all the black hair, and now I have lots of the gray hair. And over the years, I certainly very much appreciate many people, scientists, doctor, patient, family, organization, and also cooperation to make this treatment a dream that we dreamed about 10 years ago and finally come true. But this is just beginning. I think there are more challenges ahead of us, and there are evolving issues will come out, and many of the issues, many of questions will come out in this meeting. Without let me first, this panel, the panel 8, we're going to focus primarily on the clinical and patient perspectives of this enzyme replacement therapy. And the first two talks will be given by the doctors actually being taking care of patients with Pompe disease, have a great expertise in the clinical and also in the research setting. Then followed by Broekgaarden of the IPA, and she's going to talk about this from patient and organization perspective. So the first talk is by Dr. Kishnani. Priya is now at Duke University Medical Center, and she is chief of the medical genetics at Duke. And Priya has been involved in Pompe disease research for many years, actually before the first conference. She started with laboratory work and later moved to the clinical trials. So she again is one of the doctor, has lots of experience in dealing with patients and also the clinical trials. So without further introduction, let's. I'm going to give Dr. Kishnani for the first talk. Yes.
Good morning. I really wanted to thank the houses, the AMD and the IPA for giving me the chance to speak here. It truly is, I think, has been a wonderful year, and I think a real benefit for all of us here to see our patients finally getting a treatment that I think all of us have worked for so many years together as a team to get an approval. And as Whitey and as Arnold Reuser and Randall House said, I think this is just the beginning. I think we have lots of work still to do, but the good news is that the work has at least started. And I'll try and focus first on issues related to the clinical trials that led to the approval for Pompe disease. And I think there are a few things that I want to point out. This is fairly historic because this is for the first time that trials that were conducted in children actually got broad label approval in adults across the disease spectrum. Typically, it's always the other way around. The adults are where the clinical trials are done, and then you try and extrapolate or get the information down and get treatment for children. In this situation, I think It really is very historic and wonderful that we've been able to get approval across the board for all patients with Pompe disease, with, of course, post-marketing commitments and requirements that have to be fulfilled to truly say that this is a benefit across the disease spectrum, that is, even in adults. So I think I really want to point out just very quickly about the registration trials that were submitted both to the European Union and also to the US. And I'll focus really on the two studies, one which was on a total number of 18 babies who were less than 6 months of age, and the second trial which was on 21 babies who were between 6 months and 36 months. And as you can see, these children had definitely more advanced disease and could be on a ventilator when they started treatment. These children had very severe end of the disease spectrum, but were not on a ventilator when they first started treatment. They, of course, both had the heart involvement, which we see in babies with the infantile form of Pompe disease. And so really to say is that this is the study characteristics of the patients. In the first study, they were 1 to 7 months of age. In the second study, they were anywhere up to 3.5 years of age. And in the first study, as I said, none of the babies were on the ventilator. In the second study, there were 16 out of 21 who were not on the ventilator, but there were 5 patients who were already on the ventilator. And I think this is important because it really now lets us understand what happens when the disease has progressed a lot. And I want to really point out that 6 out of these 39 babies or children who were enrolled were what we are called cross-reactive immunologic material negative by Western blot. By this, what we mean is that they did not make, you cannot see any protein or any enzyme when you look for it. So they did not make any protein. And the reason I point this out is I think we've got some better understanding as we've gone along with how these patients have done. So this is the first trial, and they were put on 2 doses, 20 milligrams or 40 milligrams per kilogram of the myozyme every other week. And this was conducted for 52 weeks. The endpoint which was requested or asked by the FDA was really not just that the babies were alive, because a child can be alive but still be on a ventilator. So that is a good endpoint, but is that good enough? Does this enzyme really work? So the primary endpoint which was looked at in this study was babies who were both alive and free of being on an invasive ventilator. And I think all of us know in this room that babies who are not treated with infantile Pompe disease typically die by the first year of life. So what was being asked is that they needed to be both alive and free of ventilation at 18 months of age. And this is what we were able to show, that at 18 months, all 18 of the babies were alive, and 15 out of them were both alive and were not using a ventilator. So this was a very, very significant outcome and a very promising outcome, and it clearly is contrasting with no overlap with what happens if a patient is not treated with enzyme therapy. But I want to also point out that it's not that every patient that participated in this clinical trial did extremely well. And so I'll start with just showing you the least responsive patients. So yes, they were alive after 52 weeks or after 1 year of treatment, but these children, 5 out of them, were still not really walking. They were still had what we call very minimal gains in terms of a motor response. And I'm hoping this is not going to go on this way. And then I'll show you what we consider an optimal or a very good response. Here is the child after 52 weeks of therapy, is clearly alive, but as you can see is not really doing much still. So yes, this is a benefit of therapy that the baby is still alive, but this is what we really want to see. Patients who are doing really well and who are able to have independent mobility. So this was still a contrast even in what we called a good response to therapy. This is not as good as what we are seeing over here, and this is where we have a lot of work of how to improve and how to do things. The second study, which was in older children, 6 to 36 months, clearly had some of the very advanced cases of patients with infantile Pompe disease, and some of them who are what we say are the early juvenile who have some more enzyme activity and thus could survive to that age when they were first treated. And what I really want to show you is that there is still a difference between the two groups. Yes, there was in terms of being alive, in this trial 100% were alive, that is in the first study. In the second study, 76% were alive after 1 year of therapy. If you look at now raising the bar of being alive and not using a ventilator, here 83% were alive after at 18 months of age. Here 69% were invasive ventilator free after 1 year of treatment. So clearly right here we're also seeing that there are differences when you start therapy. The earlier you start, the better your chance is to have a good outcome. But I think the contrary has to also be stated. Not necessarily that if you start early, are you always going to do well. And I'm going to try and show you some of that information. And this is actually the video clips that we had shown to the FDA when we had looked for the broad label approval, really showing that this is the kind of dramatic response that we've been able to show on therapy on patients with infantile Pompe disease. This is something I think that anyone in this room who has treated patients with Pompe disease can clearly let us know that this is not what you see without treatment. Here we are seeing children who are walking and really achieving milestones and able to celebrate birthdays and doing things that they were never able to have done before. So this was very convincing, very moving, and I think it got the FDA's attention that yes, this is really a life-saving therapy. We have been able to make a difference. What we also did show at the FDA were the patients who did not show such a good response, because I think one has to be honest that this is still a lot of work that needs to be done. So in terms of how do these patients manage on the enzyme therapy, in terms, did they tolerate the enzyme therapy well? All of them, or 89% of them, made some antibodies to the enzyme. And this, I think, is something we have to recognize. When you're injecting a foreign protein, the body does respond by making antibodies, as we call it. This is also true of other lysosomal storage diseases. But what is the role of those antibodies? Does it really come in the way of the response to therapy? That's really the question. The interesting thing that we saw is that the CRIM-negative patients that I talked about earlier had the highest titer and the highest level, means they stayed high, the antibody titers, throughout the course that they were receiving the enzyme therapy. And 3 patients actually had what we call inhibitory antibodies, so it was coming in the way of performance of the enzyme or the myozyme that was being given to the patients. So this is something we have to keep in mind. So you'll ask me what's going on with these patients right now, what happened to them after 18 months of age. At the current time, 13 out of the 18 patients continue to be alive, and the age range of these living patients is from 29 months to 44 months. So very close to 4 years of age, once again something that we would not have seen without enzyme therapy. Out of these 13 that are alive, 9 out of them continue to be alive and free of invasive ventilator support. So really to let you know that yes, in some patients the disease progression, or some of them still do end up on a ventilator despite being alive. And out of these 9 patients that have made these significant motor gains, 7 of them continue to be independent walkers, and 2 of them are independent sitters. So I think these are huge, huge motor milestones to achieve in infantile Pompe disease. Now what happened in the group that was between 6 and 36 months of age? Out of these, 15 out of 21 are alive. They continue to be alive. The age range is from 3 years to 6.8 years. So clearly we've now made a huge shift in terms of the natural history of this disease. And in terms of those who were not on a ventilator when they started, 8 out of the 16 continued to remain ventilator free. And out of these, 3 of them are walking and 8 of them are sitting. So once again, I really represent a group of physicians, and as you can see, I think there are more physicians than patients that were in these trials, just to let you know that it really requires team effort. These are very complicated children, very complex, lot of work, and so I just represent, I think, what was truly a global team effort to bring these trials to bring success. So now, let's go on to the next part. We've got a treatment. This is how we got treatment approved for Pompe, both in the European Union and also in the US. But I think that there are some things, and this is clearly a long list, and this is just the beginning of a list. How do we really identify factors which are going to affect the response to treatment? I think one thing that comes out very clear is what is the residual function of the child when they started therapy. If they come in really in very advanced stage of the disease, I think the response to therapy cannot be as dramatic as when you've got more preserved muscle when you start therapy. So this really is, these two really are similar. What is the amount of pathology before you started therapy? This is work done by Dr. Rabin, the muscle fiber type, and so I think she will focus on this in her talk tomorrow. And the third is, as I talked about, the cross-reacting immunologic material. I think this is very important because it has implications, not just for children, but I think for overall management of even adults with Pompe disease. So I really want to just show you video clips of if your baseline is good, your chance of doing well is very good. So this is a child who started therapy, although at age 8.2 months, you can see has good preserved muscle function when the child started therapy. And you can see that this little boy, he was treated at Duke. He's kicking his legs very well, moving. He still had a very enlarged heart, was quite delayed, of course, in terms of his motor milestones. I think if the lights and this is him after 52 weeks of therapy. This child actually started walking when he was 1 year of age. So this is really to show that if you start early and you have good preserved function, your chance of a good response is extremely good. Now this is what we call a child who's not had the best response. This is a minimal responder. This is to show you at baseline when this child started therapy, he was 6.2 months, so younger but had more disease burden or much more involvement when he started treatment. And here what you can see is this child was very involved, had minimal movement of his legs, already was requiring some support. As you can see, this is a very involved baby and had even very little involved movement of his arms. And this is him after 52 weeks of therapy. So he continues to be alive, but clearly there's not much change from when he started to here, other than the fact that he's still alive. He's now on a ventilator, requires tube feedings, and continues to have a lot of motor involvement. So I think this is one important factor, that if you start before there's a lot of damage to the skeletal muscle, your response, the chance for a good response is much more than when you have a lot of involvement when you are starting therapy. So this is one situation. This really correlates very well with the amount of pathology in the skeletal muscle, and I'll leave a lot of this for Dr. Rabin to talk about tomorrow. But when there's a lot of muscle damage that has occurred in terms that there's rupture or leakage of the glycogen out of the lysosomes, clearly these are not the group of patients or the group of muscles that can respond as well to therapy. So this really has to be kept in mind. And this is again work from Dr. Rabin, and she was kind enough to share this with me, is this the fiber type, the kind of muscle fibers we have, or the differential muscle fiber types in different muscles, type 1 fibers versus type 2 fibers, they show a difference in terms of clearance of glycogen, in terms of response to treatment. And I think I'll leave this for Dr. Rabin to talk about, but I thought we have to start learning. Now let me talk about a little about the CRIM negative that I talked about, that is in patients who do not make any protein. And so we looked really at the group of patients who were CRIM positive, that is who make some protein, versus those who had no protein. And so we looked at the group of children who were less than 6 months, because we've always said that the younger they are, the more chance they have for a good response to therapy. So these are 19 babies who are CRIM positive versus 9 babies who were CRIM negative. And I'll try and focus on what happened to these babies. Let's look at how many of them were alive and ventilator free over the course of time. If you look at the babies who are CRIM positive, out of the 19, 11 out of the 19 are both alive and free of the ventilator. So yes, they could be alive but on a ventilator. I'm discounting that. I'm just talking about those who were alive and free of the ventilator. So close to 60% of them were both alive and free of ventilator. If you look at the babies who were CRIM negative, you see that there was no real difference when they started therapy. But if you now look at how they're doing, none of these are both alive and free of ventilator. All of them are either deceased, and actually of the group, one of them is alive but who's ventilator dependent. So this really was the first for us to start realizing, and I think in the first paper that came out of the group at Duke from Dr. Chen, where out of the 3 children who were treated with Pompe disease, 2 out of them were CRIM negative, and both of them did not do well. They started to decline. So this was a hypothesis that had started fairly early. So now we looked at left ventricular mass or at the heart response, because we've always felt that the heart responds very well to enzyme therapy. So even here, if you look at the CRIM positive versus the CRIM negative group, you can see that the decrease in the heart size after 52 weeks of therapy is 66%, so much more in the babies who are CRIM positive as compared to those who are CRIM negative. So a difference even in the heart, where we've said that there should be a very good response. Now if you look at the biomarker, this is a byproduct of glycogen breakdown, which is something that which we have monitored in the clinical trials to see how these patients are clearing glycogen. And so this is a way of seeing glycogen burden at baseline rather than doing a muscle biopsy, and then to see how they track over the course of time. So as you can see, for the babies who were CRIM positive, there was a drop of 58% decrease after 52 weeks or after 1 year of treatment of the amount of this biomarker that they were excreting, telling us that they were efficiently or had efficiently cleared glycogen. Whereas if you look at the CRIM negative patients, they initially started to drop, but then they start to increase. And after 52 weeks of treatment, not only are they the same, they've actually increased in the amount of the biomarker that they're excreting. And so these are the trends showing that the patients all start out with increase in the amount of the HEX4 or the biomarker, and over the course of the time they decrease. But if you look at the CRIM negative patients, they start out higher or with an increase in the amount, they come down into the normal range, and then they start to increase. So clearly a very big difference between the patients who are showing a good response to therapy versus those who are not. Now let's look at the motor response, because that was something else that we were looking at in these babies. If you look at the CRIM positive babies, once again, when they first started out, they were extremely weak when they started out, and this median number of 6 really tells you that they're pretty much not doing a lot. They're functioning at probably a 1 month or 2 month level in terms of development. So no real difference between the two groups, between the CRIM positive group and the CRIM negative group. Now you look at them after 26 weeks or after 6 months of treatment, there is a response. So the CRIM positive groups have increased from a number of 6 to 25. So a positive and increasing number tells you that they're doing better in terms of motor response. You look at the CRIM negative, they've also showed a response. So they've done better than when they were at start. But now you follow them out longer. At 52 weeks, you see the CRIM positive group continues to respond. And this number really comes out to about an 8 or 9 month old in terms of development. So yes, they are behind, but they're continuing to make motor gains. You look at the CRIM negative, they're back to where they started, not doing anything. So this information really now tells us that something has to be done for these children who are CRIM negative, because even if we start them early on treatment, we are not able to give them a good response for these, as I've shown you in this data. So we also looked at the antibody titers and said, is there a difference in the antibody titers in the babies who are CRIM positive versus those who are CRIM negative? So here you can see that after 72 weeks of treatment, the median titer for the children who are CRIM positive is starting to come down. Whereas if you look at the CRIM negative, they start high, they get higher, and only get higher. So clearly there's a very big difference even in the antibody titers. And the one thing I want to really point out is that all adults really are CRIM positive. I really want to clarify this. So this really applies to a subgroup of patients with infantile Pompe disease who really have 2 deleterious mutations where we have to start really worrying. And so this is what I want to show you, is that you start out even with a good baseline. Here's a patient who started out with a good baseline, started at age 7 months, at age 52 weeks was looking, or after 52 weeks of treatment, this patient looked like was still doing well, but was actually a CRIM negative baby. And then you see this baby, after learning to stand or after being able to stand, subsequently declined, became invasively ventilated, and then died at 70 weeks. So this is the child to show you that here the child started with a good baseline, but after 52 weeks of therapy still looked reasonable, but then started to decline. So this is the group I think that we also have to think about as we move forward. So this is the child at baseline, and this is the child at 52 weeks. But in this child, already the antibody titers were up, and the elevation of the biomarker that's being excreted was starting to go up. So we were starting to worry, is this child really going to do well? So here this child is continuing to gain milestones, but subsequently declined and then died. So I think there really is a need for recognition and intervention for the CRIM-negative patients, because I think it's going to have broader applications. Really, if we are able to suppress what we call this immune response that they're developing at the outset, that's before we start enzyme therapy, it's clearly going to benefit that group of patients. But I think it's also probably going to benefit the patients at large. If we're able to bring down the antibody titers, they may have a more robust response to enzyme, and we may require a lower dose for even patients who are CRIM positive. And I think this does not just apply to Pompe, but I think it has broader applications to other conditions where we are worried about CRIM negative and antibodies like hemophilia, Gaucher disease, mucopolysaccharidosis. So I think that the lessons that we learn from here are going to be very useful. So now I really want to go very quickly to the next of a multidiscipline approach to care, because enzyme therapy is just one component of care. And so we recently published in the US, along with, in collaboration with the American College of Medical Genetics, and I know a similar consensus paper is coming out from Europe, really looking at how do you care for an individual with Pompe disease. And I think this information is very useful for the patient community to be able to take it to their caring physicians so that they can look at what is now considered standard of care and of management, so that they can get these benefits rather than having to struggle with the insurance companies who do not want to help. So now I want to really focus on some aspects of cognition in Pompe, because I think this has been a big question that has come up, is are we unmasking brain disease in children with Pompe disease who otherwise would not have survived their first birthday, because we know that glycogen is everywhere. It's also in the brain, but what really happens to children with Pompe disease? As they grow older, is it really affecting their development? So I'll just show you samples on the two oldest patients, one who was 7 years and 1 month, and this is what we call the WISC, and this is really used for looking at how the child is doing. So the average is about 100 plus minus 15. And so if you look at the full scale IQ of this child, we just recently saw him at Duke, he's very well in the average range. So they continue to do well. So what does this child really do? He's a rising second grade student. He goes to the general education classroom. He has no special education services at this time. He plays baseball. He's a very good hitter, but he struggles to run to first base. So he does have some limitations still. He's currently learning to swim and is able to swim laps. Second child, 5 years, 4 months, once again on the WISC. How is this child doing overall in terms of IQ? Clearly in the average range. What is this child doing? So we were able to do what we call the Vineland, trying to see how child is functioning on a daily level. And you can see that these children, once again, are doing overall very well. They are functioning very well and in the average range. He's rising kindergartner. He's in a regular classroom with no special needs. Once he's an excellent swimmer, but some fatigue when he's running a lot. So this is now looking at it in a larger group of patients, once again to show you that overall they are developing and they are showing mental progress. Now, all subjects that we have seen show positive changes when you look at the raw score. There are limitations to these testing batteries because there's a motor component and a mental component. And we know that the motor component in these children can sometimes drive the overall score. So I think trying to sort these two things out very carefully is important to say that is the child continuing to develop. So I think this is some work that we are continuing to do to see, because I think we owe it to them. We've changed the natural history, so I think we've got to learn more. Now brain imaging, this is something else that we have looked at. There are some very peculiar changes that we are seeing in the brains, and this is more in the infantile group. There's an increase in the space here, in what we call the subarachnoid space in the brain. And this is at baseline at age 6 months before this child started therapy. At age 9 months, it had completely resolved. So I didn't pay much attention to it. But then as we continued to follow, we saw this in 75%, in 15 out of the 20 children that we followed. They've all got this space, with this fluid here, which is resolving in some and has resolved in some. But we don't have a clear understanding, and I think looking at the animal model will be useful. You can see here it's fairly dramatic, this dark black material, but you can see here that it's resolving, but it's still there. So this is something else. I looked at the literature and saw that it's present in about 12 to 16% in the general population. It's seen more in premature babies. But here what we saw was it was in 75% in the baseline scans, and none of these were premature babies. And out of these 20, we've had 6 who've had follow-up scans. It's completely gone away in 4 of them, but it continues to be there in 2. It's resolving. So I think this is something else we really need to look at. CNS pathology has been reported. I think Ans had reported an increase or hyperthermia in one patient with infantile Pompe disease. There's a question of whether there is central nervous system involvement. So I think continuing to monitor is one of our responsibilities. Hearing in Pompe disease, once again, this is an issue. This was reported in 2004, hearing loss in infantile Pompe disease. So we continued to follow this. What really is the hearing loss? Is it because of middle ear collection, because these children have weak oral motor, which even the adults have? And is there also a combination with central nervous system? So this is what we saw. We followed 23 children at Duke, and what we looked at were these following hearing tests. Don't need to go into that. So 22 children were ultimately tested anywhere from age 2 weeks to age 18 months. And one child could not be tested because was in the pediatric intensive care unit, and so we were not able to do it. I think it's important to know how these children are before they start. It's important to know if they have middle ear effusion, because if they have middle ear fluid, you're not going to get a clear understanding of what's going on, whether there's central nervous component involvement or not. So for 24 out of them, 24 years this is, or 12 children, had abnormal tympanometry, or that means that they had fluid collection in their ears. And so we needed to take, and I'll just show you an example of this. So here, if you look at the autoacoustic emissions, which is trying to tell you about central nervous system pathology, it was absent in 19 of them. But they also had an abnormal tympanogram or middle ear fluid. So I think this is something else that we have to follow as clinicians very carefully. We've seen it so far in one patient, a sensory neural hearing loss. This was after 6 months of treatment. But this patient also had a number of medications. I think this is another important thing we have to remember. When on therapy, we've got to be careful about the kind of other medicines our children or adults are receiving. For instance, a number of adults may have a higher cholesterol and are put on statins, which can worsen the myopathy. Yes, it lowers the cholesterol, but it worsens the myopathy. So similarly, we have to be careful about the kind of medications. If they are toxic to the ears or can result in deafness, this can then compromise an already compromised child. So really what we saw is that the bulk of children really have middle ear dysfunction. 71% of them, 90% of them at 26 weeks, but then over time, 42% of them, telling you that as they sit up, as they do better, the chance of collecting fluid in the middle ear really goes down. And so the hearing status, what we saw, and this, actually one of our audiologists did her whole PhD thesis on this, is that there was normal or adequate hearing in 81% at baseline, and then after 52 weeks, there was 87% that was normal. I think the key that we were able to show was that autoacoustic emissions, which is a way of looking at brainstem involvement or central nervous, can tell you about what's going on in the brain, but it's meaningless without further testing. The reason why I bring all this up is I think we've all got to be very clear how we are managing the patients before we're making any kind of judgment call on them. And so here we recommend really that you have to add what we call a tympanogram to help with the autoacoustic testing. Now, long-term motor response. I really want to show you, yes, it's great, you start early. These children are doing well. This is him at age 5 years. So this child, yes, is doing very well at this point. Another one started at age 2 months. This is him at age 4 years. This is him at age 7 years. Patients who are doing well, we still have some issues at hand. So this is to show you that there continues to be neck flexor weakness in even what we call the good responders to therapy. You can see that they have difficulty really with these muscles here. Yeah, they're also very busy, right? This is one. And then here, they do have compensatory gait still. You can see that this child here, although doing very well, still has some weakness here. And here, this child here is compensating in terms of having to use his pelvic muscles. to be able to move. And here is a child who's doing extremely well. Yes, walking up and down, doing very well. We made him do this many, many times just to show you that this is after many times. You can see that he's now starts to show some weakness. So I think as we've all recognized in this room, yes, we've made some great successes, some great stories, but there's still work at hand, and there's still a lot that we need to do. And this is really a lady, a 60-year-old who started at baseline where she was unable to actually get out and walk on her wheelchair. This is her after 6 months of therapy. And this, we just saw her last week in our clinic. And this is just remarkable to show that we were able to show some improvement in therapy after 6 months. So I think, in conclusion, I think enzyme therapy has changed the natural history, but we've got to work further to understand what's going on. What is the reason why there's a response to the variation in heart versus skeletal muscle? Why is it that some skeletal muscle fibers are working better and doing better than others? And I think doing this with a multidisciplinary approach is essential. Newer therapies should also be considered. Improvement of targeting, use of chaperone therapies, gene therapy maybe in the future. And we really have to be very, very grateful to all the organizations, to the patients and their families for helping us do this. And this is a financial disclosure. Thank you.
So I want to introduce our next speaker, Dr. Ans van der Ploeg. And I'm sure many of you know her. She's another famous doctor you need to know of. Anne is from Rotterdam, Netherlands. And again, she has been involved, started with basic research in Pompe disease with Anna Reuser, moved to clinical trial and taking care of a lot of patients. Anne?
I'm happy to be here on this meeting organized by the IPA in combination with the AMDA. It's always a pleasure to be here in San Antonio and at the Alamo. And I also would like to introduce you to our hospital. And this is Rotterdam over here. I think I do it like this. This is the faculty. This where Arnold is working. This is the Sophia's Children's Hospital. That's where I'm working. I'm working at the Department of Metabolic Diseases and Genetic. And this is the hospital for the adults. And they are all connected, so we have a good collaboration with each other. And that's very important in Pompe disease, as Priya just mentioned. It was a great year, and all of the previous speakers already mentioned it, that the biggest achievement of this year was the approval both by the EMA and the FDA. And I had the privilege to be part of the process that finally went to the approval. The cloning of the gene, the development of the production methods, and finally the preclinical studies in mice and in the mice, and eventually the treatment of the patients that started in 1999. Rotterdam has a long line of research on Pompe disease, and that's a short introduction. And I think this long line of research is very important in order to translate finally basic science into clinical practice. And here, this is the thesis of Arnold in 1977. In fact, this is my thesis in 1989, which focused on looking whether it was possible to correct cells in culture and the cloning of the gene, the production of milk of enzyme in transgenic rabbits and the knockout mouse model, and finally the clinical trials. And this is the most recent thesis, and that's Marloes, and Marloes Hagemans will give a lecture tomorrow. But these type of things we can't do without a good collaboration between patient organizations, the industry, and the university. And through this mutual interest, finally, it's possible to develop a drug. And I also would like to stress that the input of patients is extremely important in this process. We're starting a learning curve. And in fact, it all started already in 1932 with Pompe's disease, as Randall House mentioned. But in fact, the first important thing was in 1963. The next important thing was that the first lysosomal enzyme was discovered, and that was alpha-glucosidase, the deficiency in Pompe's disease. And over many years, many lysosomal enzymes have been discovered and their genes. And now we're starting the learning process of what are the effects of enzyme therapy. There are many challenges, and Priya already focused on it. The infants, when do we need to start a treatment, and what are the long-term effects? And when do we start to treat the children and the adults in order to avoid, finally, ventilator dependency and wheelchair dependency? Pompe's disease is a spectrum of disease. And here you see the clinical course of 36 patients we've seen in the Netherlands. And each bar represents an individual patient. It shows where the symptoms start, and here the end of the bar is the current age of the patient. At the far end here, you see the classic infantile Pompe patients who die within the first year of life. But in fact, if you see, Pompe's disease can start at any age, and as late as 60 years of age, up to ages of more than 70 years. The main cause of the variation, but there are also secondary factors, is the deficiency of alpha-glucosidase. In conclusion, all patients with Pompe's disease have the same disease. But in infants, there is a profound deficiency of alpha-glucosidase. Here you see the alpha-glucosidase activity on the axis, and here of control individuals. And in children and adults, there is some residual activity. If we come then to the challenges of treatment, we see that the challenges are the largest in the infants, because the gap to close between normal and the actual value is the biggest. So if I go back to the spectrum and we go to the process of the clinical trials and what we learned so far, there have been trials started in classic infantile, in the older children, and currently in the larger group of adults and children in the LOT study. I would like to go through the various groups of patients and to see what we've learned over time. And it is, I think, complementary to what Priya said. First of all, the process in classic infantile patients. I show you here the process, how the disease progresses. A baby who starts to have symptoms shortly after birth, who is still able to move the legs, and here a patient at 7 months of age where there is complete paralysis and all muscle function has lost. These patients usually die before the age of 1 year, as you can see here, and it's a similar type of slide Priya has shown. You see that the majority of patients who are not treated die before the age of 1. This slide shows the results of the 17 patients that have been published so far. That means the first patients treated by us, by Duke, and by Klinge in Essen, and the recent CRIM positive study of Priya. In total, 17 patients have been treated, and if we look at the data of these studies, when we look at survival over 3 years, in total 8 patients have survived. If we look at the number of patients who do not need survival, it were 5, but eventually of the 8 survival, it were 4. If we look at the number of patients who learned to walk, it also were eventually 4. And if you look then at the months in which they started treatment, we see that if if patients started treatment after 5 months of age, none of them learned to walk or did not need a ventilator. These are the data from Rotterdam, and I would like to go in a little bit more detail because these are the patients I know best. We've treated 8 patients. 4 of the patients were in the previous slide. 2 of the patients have died. 3 of the patients are 8 years old, and one of these patients learned to walk. And this is one of the patients you just saw. If there is a late stage of treatment, these milestones are not reached. From this experience we learned, and we tried to treat the patients earlier. And if we look at that, there are more patients who learn to walk. And of these patients, 3 patients remained without ventilation. But it's also shown that the age of the patients, here the age in months, is not the only factor. And it's more the state of the disease that is important, what's the result of therapy. Here the effect of the heart. If we look at the heart, over about 7 years of treatment, the heart in general responds well. If we go to the motor function, it's very much important what is the condition of the patient at start of treatment. And you just heard, if there is paralysis, it's impossible to recover. If there is a good function at start, patients respond, and here this is the AIMS, this is the normal curve, and this is the upper and lower limit of normal. But also, in this group of patients, there may be a patient who is responding initially well and then goes down. And what happens here is in the majority of cases a respiratory problem. And from the beginning, although this patient is doing well, I always had worried about his respiratory condition, insofar that he breathed a little faster than normal and frequently had respiratory infections. Overall, you more or less can predict, I think. And here again, the patient, if there is complete paralysis and there is no function, I think it's not realistic to assume that will recover, that muscle function will recover. And that explains why this patient at the age of 8 years has paralysis and has remained ventilator dependent. She started ventilation at the age of 7 months when she started treatment. But we also have the positive results. This patient here, who started treatment at 40 days of age, she needed CPAP in the initial phase of her life. She needed nasogastric tube feeding, but here she is at the age of 2 and doing very well. And here another patient at the age of 3 months and at 2 years and at 7 years. In fact, what you see here is that this patient shows a similar type of results, but here at the age of 7 years, you can see that some symptoms of disease have developed, and that the way how he's placing his feet and going up the stairs is not completely normal. If we compare it with the fact that these patients normally die before the age of 1 year, there is a significant effect of enzyme therapy. But what we also learn is, especially in the infants, that the balance is delicate, that the timing to start treatment is extremely important, and these children are prone to maintain or develop some form of residual disease. When I come back to the spectrum, the older children and the adults. If you look at the non-classic or late onset forms of this disease, the major characteristic is that the disease progresses more slowly. And this is a result of the IPA survey of 255 patients, and probably also contributed. And what's shown here, that the part of the patients that is ventilator dependent are wheelchair bound. And you see that this after 5 years after the diagnosis, 5 to 10 years after the diagnosis, and 15 years after the diagnosis. And 50 years of the diagnosis, 80% of the patient is wheelchair bound or uses a ventilator. And you see that this period is much longer than the period that you see in the progression of disease in the infants. But Pompe's disease is also a progressive disease in adults. If we look at the number of ventilator hours, it increases significantly over 2 years' time. So it is a progressive disorder. If we then come back to the level of enzyme deficiency, the gap to cross is less. So the disease progression is less, and the gap to cross is less. But also what we learned there is that it is very important to start treatment early. Here, a boy of 11 who started to have symptoms. At 15 years, he became ventilator dependent after a scoliosis operation. And here he is at the age of 32 with complete paralysis and complete ventilator dependent. Well, this patient was started when he started treatment when he was 11, and currently he's 18. I would like to show you the results. This is the patient. This is the results of the pulmonary function. 3 patients, 2 patients were ventilator dependent, and all 3 patients were wheelchair bound. And this is in the 32-year-old patient, the ventilatory function before start of treatment, and after start of treatment, the pulmonary function stabilizes. While in the youngest patients, there is an age-related increase of the pulmonary function over time. And this is the time, 6 years of enzyme therapy, and here the patients were transitioned to Myozyme. This is the effect on muscle strength. And over 6 years of therapy, there is a significant improvement in muscle strength in all. But this improvement in muscle strength is minor in the most severely affected patients, moderate in the intermediate patients, where there the muscle strength is major, the major improvement is in the upper body, while there is a tremendous improvement in the youngest patient. If we look at the youngest patients and we look at the handheld dynamometry, the muscle strength in this normal piece, it goes like this, because the patient grows, here 11 years old, here 18 years old. Also the muscle strength will increase in his peers. But then over 6 years of time, you see that the muscle strength becomes the same as in its peers. Then to the effect of therapy over the 6 years, it's a tremendous response, and the patient functions normal at 18 years of age. But we also need to realize that only a minor number of patients will reach this response. And what we also found out is that the quality of life in all patients who participated in this first trial improved. And I think it's a major thing to follow what is the impact on enzyme therapy on the quality of life. And I think it's a major thing that these type of things, graduating from high school and going into law, are achieved. I would like, with this knowledge we got from this first 3 patients, a study was started in 5 patients who had an age of 5 to 15 years. And these patients were all freely ambulatory and ventilator free, except for 1 patient who needed ventilation during the night. And I show you some of the results. It's still preliminary. But over 50 weeks of treatment in these 5 patients, in the 3 patients who had a pulmonary function below 80, there was a significant improvement of the pulmonary function related to peers in supine position. And this is, we did not do this, the calculation yet, the improvement over 74 weeks of treatment. Here the 6-minute walk test, also one of the endpoints in the LOT study. There was a significant improvement on a group level in these 5 patients over a year, and these are the results over 74 weeks of treatment. What does it mean for the patients? What we realize treating patients with enzyme therapy is that it takes long to get a result. And what I show you here, I ask the patients to come from a lying position to a sitting position. Here, after 2 years of treatment, here after 26 weeks of treatment, and here at baseline. And at the end, here she is permitted to use her arm to come to a sitting position. You see that it's a slow progression, it takes long, but the difference is significant. So what did we learn so far? Over a year from this LOT study, a mini LOT study, preliminary data show that myozyme in this dose, 20 milligram per kilogram every other week, leads to significant improvements in predicted FVC and in the motor function. But over this period, muscle strength does not show a significant improvement. It remains stable, and treatment is well tolerated in all. And 3 of the patients had the IVS1 mutation, and that is the most frequent mutation that is seen in the late onset patient population. Then to the final group of patients, the LOTS patients. This is a study that's currently ongoing, a study in 19 patients worldwide, where 60 patients receive myozyme and 30 patients receive placebo. This study is ongoing, and Rotterdam is participating with 20 adults and 2 children. I would like to go a little into muscle pathology and just to relate the clinic to muscle pathology. And for a comparison, I used these 3. Muscle pathology and regeneration. What is realistic to expect? And when we look at this tree, it's a tree that's growing and has leaves. And I think we do not have any doubt that this tree will grow next year and will get leaves again. If we look at this tree, it's a dead tree. And I think it's unrealistic to expect that this tree will get leaves next year. But then we go to this tree. What type of tree is it? Is it a tree that is dead? Is it a tree that is going to die? Or is it a tree that's going to blossom and it's in spring and leaves are coming? So I will show you what I mean with pathology. Muscle is the largest organ of the body. 40% of the body contains of muscle. And this is the muscle. You have a bundle of fiber. A fibril. Okay? So it contains the muscle, the bundle, the fiber, the fibril. And there in the fibril you have the filaments, actin and myosin. And it crosses over each other, and that's the way how a muscle contracts. And that's how it looks under the microscope, an electron microscope, a very high magnification. It's over here, actin and myosin, it's working like this. And in the initial state of the disease, you have these sugar lumps, but you see that the architecture of the muscle is rather well preserved, but these sugar bumps may have an influence on how these muscles perform in strength, because it's more adequate to do it like this than to do it like this. And that has been demonstrated in a mechanical model. And when the disease progresses, the muscle destroys and is destructed, but you only realize that you lose your muscle mass if you lose 40% of your muscle tissue. If we look under a light microscope, it's a smaller magnification than the electron microscope. This is normal muscle, and this is the muscle of a patient with Pompe's disease, with glycogen. That's the purple material. And why I would like to show you this picture is this. This is the process in the classic infantile patient, and this in the late onset patients. And I would like to go to this slide. This is a section at 3 months of age. And if you look at this section, you see that there is storage in virtually every fiber, and that some of the fibers are lost. And it's remarkable that these patients are able to function still rather well. This is a patient of the same age, but you see that the storage is much more significant, and there are hardly any normal fibers. And this is in an end stage of the disease, and all normal fibers have gone. And this is a process that takes place in 4 months' time. So it's an extremely devastating process over a short period of time. Then in the late onset patients, it takes many, many, many years. And there the storage in the initial phase is only mild and not the same in all the fibers. And also there's variation. Some fibers, even in an end-stage disease, are very severely affected and completely damaged. But in between, you may find a fiber that's still relatively normal. And you can also see it here. Here you see a fatty replacement, but here a fiber that's still relatively normal. You can imagine that it's much more difficult to interfere in this process than over here. If we go then to the effect of treatment and look at this patient, where there's still significant storage, the purple material, you can find an improvement in skeletal muscle cells in about 75% of the muscle tissue. But once it's over here, you can see it's completely destroyed and the muscle has become beyond repair. And then we can understand that this patient will remain paralytic and this patient is able to gain motor function. What we also learned, and I think this is interesting, that we looked at the response of type 1 and type 2 fibers. This is in a normal muscle, and type 1 fibers are the red one, that are the oxidative fibers, and type 2, the glycolytic fibers. And here, before start of treatment, you see damage in both fiber types. And then, after 18 months of therapy, you see that both in type 1 and type 2 fibers, the holes that are present over here, do you see the holes, are disappearing. And this is what we find in about 75% of the muscle tissue section. And I think this is a very important message, because tomorrow you will hear the talk of Nino Rabens. She has done very, very beautiful work in the mouse model, but it may be so that response in humans is different compared to mouse, because in mice it was reported that type 2 fibers are resistant to therapy, and what we find is that here also type 2 fibers respond to therapy. So I think that's promising. I come to the end of my talk. Factors that induce muscle atrophy are, of course, Pompe's disease, the disorder, but also immobilization and a bad condition with respect to feeding. So it induces protein breakdown of the muscles, and to a lesser extent, it also induces autophagy, which is not good in Pompe's disease. And enzyme therapy can help to work on this, but I also would like to stress that we need to do something else. And in that respect, I would like to focus on the recent publication of Dr. Slonen, who pointed to the fact that nutrition and exercise are important to improve muscle strength in patients. And I think these are really important factors that may add to the condition of patients in Pompe's disease. So, at the end, with enzyme therapy here, this is the start of the enzyme therapy, the duration of the enzyme therapy so far, the spectrum is expected to change. Patients who are bound to die in first year of life are now becoming older children, some of them. And the older children are becoming adults, and adults are becoming older adults. So what did we learn so far?
Back to that slide that said the name of the article, one more back.
Yeah.
So I could look at that article myself. Thank you.
Yeah? Okay. So what did we learn so far? There's no doubt, enzyme therapy is effective in Pompe's disease. Treatment of patients with classic infantile form disease, with the classic infantile form of disease is most challenging. The disease progresses extremely far, and enzyme deficiency is most profound. We also learned that treatment has to be started early, and preferably at young age, but more so at an early stage of disease. The therapeutic window in late onset Pompe's disease is expected to be larger. And also here, the preliminary data show that there are effects on pulmonary function and on muscle function, but we need to learn more about the reversibility of the symptoms. We need long-term treatment of patients to learn about the full effects of enzyme therapy. And we also need to learn more about the process by which the disease progresses and the factors that may influence the course of the disease. And we will hear more about this during this meeting. It's important that we have a learning environment and that we are sharing information. And this is the cover of an expert day we are going to have in Rotterdam. And especially I would like to focus on the front cover. This is the cover made by a Pompe patient, Helen Walker, and what she tells here is this picture of these butterflies. Shows the marvelous moment of release from the cocoon into a new being, something that all Pompe patients long for. And what's very important is that we all keep working together. And I thank everybody who helped to make these results in the clinic and in the laboratory, and the various departments, the patient organizations, and the industry. Thank you very much.
The last talk will be given by Ria Broekgaarden. Okay, and I'm sure, you know Ria in this audience, that Ria is well known, and she started with the Dutch Muscular Dystrophy Association, and later with International Pompe Association. And Ria is going to tell us about the role of patients' organization. And I know at least one role. This patient organization is to push the doctor and scientists to work harder. Ria?
Now, my name is Ria Broekgaarden, and first I would like to thank Randall House for his kind words. I don't accept them, because I accept them, I accept them, but I would like to mention the names, all the board members, because the IPA, it's a team. It's not Randall or me, it's a team. And the years from 1999 till now, the IPA board worked together with an advisory persons, and I would like to mention Marise Schoneveld van der Linden, where is Marise? Over there, who's done a lot of the work for the IPA. Ellen Muir, our treasurer. Helen Walker, you've seen her picture, painting. She's in Australia. She's sending over her warmest regards. Then we've got Helmut Ernie. Where's Helmut? Helmut is over there. He's in the advisory team. Tiffany House, our webmaster, she's over there. Marilyn House, of course, she's always there helping us, inspiring us. And me and Randall, and I do not forget anyone from the board. Yes, there's a change in the board, and maybe we will inform you about that later on to keep you a little bit curious. But there's a new team coming on the board because we think there are new things, new challenges in the future, and we need more people to be active. Okay, I've got a question. As we are patient representatives, being IPA, we always want to know more about you and your feelings. So I would like to know something about the temperature in here. Are you familiar? It's too cold, eh? Yes, that's what I was experiencing. So is there a possibility, maybe Arnold, a little bit trial and error once again to change the temperature over here. Thank you. Okay, let's go. The International Pump Association. What we wanted at our start, we started with a policy paper, and in 1999 we decided that our mission was that we wanted an early diagnosis and an effective, affordable and safe treatment and therapy for patients with pump disease. And also, our mission was to assure that there is reliable information and support to all patients and families and other involved parties with pump disease. Now, the IPA worldwide stands for, and you can read it, obtaining attention and commitment for pumpen in the process of drug and policy development. We are representatives of pump patients worldwide. We did set up and we maintained an infrastructure and therewith access to pump patients. And our activities were aimed to stimulate the development of drugs for pump disease and to accelerate the drug development process. I will go into that later on. And also advocacy by increasing awareness is a very, very important issue. Well, this is more or less the history of pump disease. Arnold Reus already mentioned the start of the whole history. We started in 1932 when Dr. Pompe described the disease. And it went on. Ans, her thesis, Arnold's thesis, but also other things were very important. Orphan Drug Act in Europe, for example. And then in the end of this line, you can see that in 2006, there was the registration for myozyme and treatment started. And there are little dots over here. It's because a long line will follow, in our opinion. Ans van der Ploeg already mentioned that collaboration is really very, very important. Collaboration with doctors, with industry, with other patient organizations worldwide. You see an arrow over here, and we've been part of the last items on the arrow, the clinical trials and development. We started as IPA when the first clinical trial started in 1999, around 1999. And I will go into more of these issues during my presentation. But when we started in 1999, we didn't know where we could find patients. And we were looking for trial and treatment centers, because if you want a drug to be developed, you need patients for the trials and you need doctors who are interested and good trial and treatment centers. We also didn't know what we were talking about. Arnold Reus already mentioned this. Are we talking about Pompe disease, or are we talking about glycogen storage disease type 2? So we decided inside the IPA it would be Pompe disease. But there's another important issue over here. In our contacts with farming and other industry and Genzyme, I realized, and the board realized that Pompe disease is a metabolic disease, but also a neuromuscular and muscular disease. And by knowing that, by realizing that, we also realized that we should try to contact doctors who were aware of muscular diseases. And a lot of patients are being diagnosed by neurologists and misdiagnosed by neurologists. So the people from farming and Genzyme were familiar with Gaucher disease, but not that familiar with the neuromuscular centers worldwide and with neuromuscular groups. That's why we started to contact not only national organizations, but also we brought the industry in contact with and doctors in contact with other doctors, with neuromuscular doctors, as the ENMC, that's a European Neuromuscular Center, a research center. They are organizing a lot of consortia for doctors. There we organized, Hans van Ploeg was there together with Volker Staub. We organized a conference about Pompe disease as well, and publication out of that they are being published in neuromuscular disorders. So raising awareness not only in the field of the metabolic diseases, but also amongst neuromuscular doctors and researchers. Okay, we asked our members to tell us, the IPA board, where to find neuromuscular centers, where to find expert centers. This is the UK, and it's just an example. We asked all the countries, and as you can see, there are 4 being mentioned over there. But the nice thing is that Rotterdam is here. You can see, now you've seen the buildings, but here's Rotterdam, the expert center in the Netherlands. Another thing that was really important in the beginning is that we convinced and that we tried to organize on a national level, and the IPA supported patient groups, to network. You can't sit on your own as a national organization. You need to network in your country. A lot of patient organizations worldwide are producing information about Pompe disease. And as every patient organization does, the AMDA, VSN, the German group, they organize conferences, meetings, publications, etc. And it's really important because you have to make a start with these activities before there are trials started. The IPA organized conferences in 1999 and in 2003 with the help of the German group in Germany. And we are here now. Now, after the really short period of time, we were very happy to realize and to conclude that there were so many patient organizations for this very, very rare disease worldwide. And in contact with these patient organizations, we asked them all the time to raise awareness in their own country, and we tried as the IPA board also to raise awareness in Europe and in Australia and all countries we were in contact with. Also, the cooperation and collaboration between researchers and industry and patient organization was a very important issue for the IPA board. And then this really, I'm so proud that the IPA started together with the Erasmus University this questionnaire, because I'm convinced that the outcome of this questionnaire has been really instrumental for the in the roadway to therapy. There's a booklet. Just see where I put it. Okay. The results are being published, and Marloes Hagemans will inform you more in detail about this questionnaire. And I think that a lot of you participated in this questionnaire, as the AMDA did send out the questionnaires also. The other thing we did was that we composed the POMPE connections. They are being translated in different languages, such as the Turkish language, the French language, the Dutch language, French language, etc. And there's a new part of it, you've seen it, Arnold, you mentioned it, it's about treatment. Another thing we did, the IPA did, was that we brought forward the patient perspective in the meeting with the EMEA and the FDA, both authorities who have to decide concerning the market approval. And we were very happy that the IPA, people from the IPA, Randall House, Brian was there as well, and Maurice in Europe, were willing and able to bring forward our point of view. That's something we did with the FDA and in Europe. In Australia at this moment, Helen Walker is also very active to talk with the authorities in her country. But also, one thing is market approval, but the other thing, it's reimbursement. And therefore it's necessary, and we did it in the Netherlands, this is our Ministry of Health, maybe not anymore because we had our, our elections are on Wednesday, Wednesday the elections, but he is, so we invited him at the VSN, and you were there as well, and we informed him about pompe disease. This is very important, and these things, these contacts with the health authorities, it's what we did in the Netherlands. It's just an example, because I know these contacts are there as well in Australia, as I told you, in Germany, in England, everywhere. But it's not only the IPA or the national organization that plays an enormous role. You yourself, you play an enormous role as well, because it's up to you to talk with the doctor. It's up to you to talk with your insurance company. It's up to you to raise awareness in your own community. And I just would like to show you this example. Maybe you, when you were in the lobby, you heard a piano music. Piano music is from Johan Bakker. He's a pompe patient. He's the president of the Dutch pompe group. And when he was still able to play the piano, he recorded this CD. It's just when you are in the lobby, just listen to this music. I think it's wonderful music. And he called it the Concert for Civilization. He did send this CD to Mr. Hogevorst, our Minister of Health. And he told him, I want to be free of disease, and I think it's a matter of civilization. So, if you have the time, please take a look at it. Now, coming back again to this arrow, what we did, you can see it. We have our IPA Genzyme conference call, our joint program updates quite frequently. There was the IPA EMC survey. We tried to get patients, to try to contact patients to assure a very short clinical trial recruitment, quick clinical trial recruitment. We had our meetings with the EMEA and the FDA. There were disease awareness initiatives. We tried to, and I will go into it later on, to bring in the patient perspective for the expanded access. Or maybe I'll tell it now. There was a discussion amongst our board, and it was about the expanded access program from Genzyme. I can't go into all the details and all the things we discussed as IPA board with Genzyme and others, but you know there are different types of respiratory care, and one of the issues was that when you are on a ventilator, there's a nasal cap mouthpiece or a tracheostomy. And the criteria for the expanded access was that someone had to be on a tracheostomy. And we thought that it's not about the solutions, the way of respiratory care, but more about the problem. So that's why we convinced, we had a lot of talks, we convinced the people in charge that 24 hours nasal cap and mouthpiece ventilation is something you can compare with a tracheostomy. Now, information and resources, I informed you about that already. In the end, we think that after 1999 till 2006, we really form a recognized source on information on pompe disease. We realized a close link with both industry and academia. We are an equal partner, that's for sure. There are open discussions. We are acting as a strong, united voice of pompe patients across the world and not as isolated individuals. And we did create a real international pompous community. There are, as I mentioned before, a lot of members. There's an activity plan, a policy paper. We organize our conferences. If there's something you would like to know about the IPA, just go to the website www.wordpompe.org. We produce pompe updates on a regular basis. There's the wonderful IPA Erasmus questionnaire, the telephone conferences with industry on a regular basis. We raised awareness, and there were the FDA EMEA contacts. But was it an easy thing to do? No, there were a lot of challenges, One of those, I will go into some of those. There was the misleading info. In 2000, there was an article in the paper, it was in the Netherlands, and Farming, the company who worked with the transgene drug, told us that there would be a product on the market in 2000. That didn't happen. Another thing was that we had to, it was about the rabbit transgene product. We had to fight the animal welfare campaign group in the Netherlands. We succeeded because they didn't want little rabbits to be milked and to produce the medicine for patients. So, but we succeeded. So they had to withdraw all their advertisements. Another complex issue we were focusing, and I don't know if it's something that's happening for other diseases as well, but to me, I think it's really something special for pompe disease. We were confronted with different production possibilities. The transgene one, then Synpec was in there as well, and later on it was the myozyme product. But were there results? Yes. I think I will go into the first point. There was a moment when the patients who were on the transgene product had to be transitioned to the new product, to myozyme or the Synpec product. And we had a lot of discussions about the optimal dosage. And we didn't agree. There was another point of view. The IPA board had another point of view than the people from Genzyme in those days. In the end, we had a lot of discussions, but the doses changed to the dosage we asked for later on. There was the Erasmus IPA questionnaire. And another thing I didn't mention is the Flying with Pompe disease brochure. We noticed that it was a little bit difficult. There were thresholds for people, especially in the United States, to participate in trials. That's why we thought it would be wise to make a brochure with a lot of tips and information in it. Marise composed it. And I think this was instrumental as well towards the trial participation. We discussed, as I said, the EAP criteria, expanded access criteria, and I already mentioned these points. But the last one, I think that because we were in contact with patient organizations worldwide, because we made something like the Flyer with Pompe brochure, and because of the fact that we informed all the patients in the different countries as national patient organizations and as IPA, I think, and we solved insurance problems. I haven't go into that, but when there was the study with the little children, the 6002 trial, there were insurance problems for these little children, and the IPA tried to solve these, and we contacted different insurance companies just to ensure a faster enrollment. I borrowed the following slide from Dr. Nareem Varawala, and she measured the benefits of improving patient recruitment times. It's important for us because the quicker you are, the sooner the results are there. But also, I think, and she thinks, it generates a lot of money. We aren't there yet. We aren't there yet. The first step is there, but we are there yet. There are a lot of new expectations and challenges as a smooth and broad worldwide introduction of therapy. Because we have to realize, being here, now there's a lot of information, with extending with wonderful doctors, a lot of information. But if you go back to Slovenia or to, now name a country, there still are patients waiting. They don't know, the doctors don't know what to do. The introduction of therapy in those countries where the knowledge is not on a high level, it means that we have to put a lot of energy in it over there. Then, transition of patients at an adequate dosage. We don't know what the adequate dosage is, but what we do know is that in the end, we would like every patient to be on an adequate dosage. Something else is the early diagnosis and screening. We are into that as well. Some projects in the Netherlands. There are, Genzyme is, of course, also very interested. And early diagnosis, not only, and a correct diagnosis, not only for the little babies, but it's very, very important, in my opinion, in our opinion, for the late onset group. Because still, I'm convinced that there are still a lot of people underdiagnosed or not diagnosed, or misdiagnosed.